Good morning. Today we are going to start our first plenary. The first plenary will be reducing mortality and morbidity in diabetes, a look at the post-SGLT2 inhibition era by Professor Arjuna Medagama. Professor Arjuna Medagama is a professor in diabetes medicine at the Department of Medicine, University of Peradeniya. He is a specialist in general internal medicine and obtained his MD medicine from PGM University of Colombo in 2005. He is also a fellow of Royal College of Physicians London and a Ceylon College of Physicians Sri Lanka. His research interest includes diabetes epidemiology, diet and exercise in diabetes, and the use of nutraceuticals. He has published more than 40 papers in international peer-reviewed journals and has presented many abstracts. He has authored 2 books for medical undergraduates on diabetes and hypertension. He is the recipient of President's Awards for research publication for many years and other awards for scientific papers. At present, he is the chairperson of the Board of Study in Medicine, Postgraduate Institute of Medicine, University of Colombo. May I invite Prof. Arjuna to deliver his speech today.
Thank you, Chairperson, for that introduction. And good morning, everybody. And thank you very much, the Council, the Sri Lanka College of Internal Medicine, and the Council for inviting me to give this talk this morning. And I will be talking on the changing landscape of diabetes management in the post-SGLT2 era. The mortality from diabetes is primarily from 3 causes: atherosclerotic cardiovascular disease, kidney disease, and heart failure. Diabetes increases the risk of cardiovascular disease several-fold due to an increase in the duration of diabetes, rising HbA1c, increasing urine albumin to creatinine ratio, renal dysfunction, and the presence of previous cardiovascular disease and other cardiovascular risk factors. Globally, approximately 1/3 of patients with diabetes will go on to develop cardiovascular disease. This is mostly due to MI and heart failure, and about half would progress to develop kidney disease as well. Patients with DKD have the worst prognosis among patients with other types of CKD and type 2 diabetes. On average, across both genders, you would see that about 11 to 14 years of life would be lost when one develops diabetic kidney disease compared to those without it. As the estimated glomerular filtration rate declines and the urine albumin to creatinine ratio increases, there is an increase in the mortality. In the presence of CKD, the deaths are mostly due to cardiovascular disease as opposed to the progression into end-stage kidney disease or going into renal failure. The triad of diabetes, cardiovascular disease, and CKD have well-established therapies and goals for optimizing HbA1c, blood pressure, lipids, lifestyle, as well as evidence-based guidance for optimizing heart failure and retarding the progression of CKD. However, unfortunately, there is no evidence from prospective trials that more intensive glycemic and other risk factor control reduces mortality. This was shown in the ADVANCE and the ACCORD studies, and more worryingly, in the ACCORD study, as the glycemic targets were lowered, there was a rising increase in the mortality. So is it time for a paradigm shift in treating diabetes from a glucocentric approach that relied on HbA1c to improve outcomes to one that reduces hard cardiovascular and renal outcomes in all patients, including those with established cardiovascular disease and kidney disease? During the rest of my talk, I would be attempting to gather the evidence for the efficacy and safety of newer agents in reducing cardiovascular death and major adverse cardiovascular events. Also, their place in managing heart failure with reduced and preserved ejection fraction and acute heart failure, and also on retarding the progression of CKD in patients with renal dysfunction. And I would just touch upon the evolution of evidence-based guidelines as well. We all know that back in 2008, the FDA guidance mandating assessment of cardiovascular safety of all antihyperglycemic agents in RCTs was issued. And these were designed as non-inferiority studies to demonstrate that the study drug was not associated with more adverse events than placebo. The primary endpoint was a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. These are the FDA mandated. However, there was no inclusion of renal safety, and some primary endpoints included additional components as well. So in this group, we have three classes of medications: the DPP-4 inhibitors, the GLP-1 receptor agonists, and the SGLT2 inhibitors. The DPP-4 inhibitors, as we know, are more or less cardiac neutral and will not be the focus of my attention during the rest of my talk. Many cardiovascular outcome trials have been conducted and completed. You can see the plethora of them. Few are yet to report in the coming months and years. Let's take some of the evidence and see what we have. SGLT2 inhibitors are useful in managing patients with diabetes. They usefully reduce the HbA1c by about 0.7%. They have useful weight reduction of about 2 to 3 kilograms and also reduces the blood pressure by 2 to 4 millimeters mercury. However, more importantly, the SGLT2 inhibitors have demonstrated multiple CV benefits. And you will see that in the shaded areas, cardiovascular death was reduced with empagliflozin. The major adverse cardiovascular events of stroke, non-fatal stroke, and MI was reduced with two agents, empagliflozin and canagliflozin. However, the most striking finding was its ability to reduce heart failure hospitalization across three agents. I have not included the ertugliflozin, one of the newer drugs, but I will come to that later. But all three other drugs have demonstrated a clear ability to reduce heart failure hospitalizations in these cardiovascular outcome trials. These changes are probably mediated through a combination of natriuresis, reduction in interstitial edema, improvement in myocardial metabolism, and improvement in the cardiorenal physiology. If I just summarize the outcome trials of GLP-1 receptor agonists, major adverse cardiovascular events are reduced only across 4 agents of the 6 that underwent testing. Those are the ones in the shaded areas. Cardiovascular death was only reduced with liraglutide. Stroke and MI were reduced again only across 3 agents, that is liraglutide, semaglutide, and exenatide. In comparison to SGLT2 inhibitors, it had no effect on heart failure hospitalization. How do they mediate these changes? It is postulated that they have more action on vessel wall inflammation and platelet aggregation compared to other agents. If I just do a very brief comparison of the two groups of drugs, 3-point MACE is reduced across both SGLTs and the GLP-1 receptor agonists. Cardiovascular death is only selectively seen in 2 agents of empagliflozin and liraglutide only. Heart failure hospitalization reduction is almost exclusively only demonstrated with the SGLT2 inhibitors. So just let me take a minute to talk about their effect on heart failure and diabetes. Diabetes is associated with a worse prognosis in patients with both heart failure with reduced and preserved ejection fraction. Diabetes is indicated with those red lines, and non-diabetic patients are in the blue lines, and you can see the difference. The promising results on heart failure hospitalization prompted the initiation of dedicated heart failure trials on patients with and without diabetes. The DAPA-HF and the EMPEROR reduced included patients with a reduced ejection fraction, whereas EMPEROR preserved and DELIVER trials included patients with a preserved ejection fraction. The patients included in DAPA-HF and the EMPEROR reduced trials, about half of them had diabetes. All of them had a lower ejection fraction, less than 40%, with a high BNP level. They had some degree of renal impairment, and they were on guideline-directed heart failure treatment as well. A meta-analysis of both trials have shown that the dapagliflozin and empagliflozin reduced heart failure hospitalizations as well as reduced cardiovascular death. The accumulating evidence favoring SGLT2 inhibitors in HREF led to their inclusion as a class 1 recommendation for the management of heart failure in 2021 in most guidelines. This is in addition to the RAS inhibitors, beta blockers, and the MRAs. The black hole of heart failure is considered to be the heart failure with preserved ejection fraction, for which there is no established therapy at present. A significant proportion of patients with diabetes also have heart failure with preserved ejection fraction. Previous trials in heart failure with preserved ejection fraction have failed to achieve their primary endpoints. In this background, the Emperor Preserve trial was undertaken, and it was published about 3 weeks ago. This trial included nearly 6,000 patients with a ejection fraction of more than 40% and had either diabetes or they did not have diabetes. The primary endpoint was a composite of cardiovascular death or heart failure hospitalization, and all these patients on background guideline-directed heart failure medications as well. The Emperor Preserve trial showed that patients on empagliflozin had reduced cardiovascular death or hospitalization for heart failure with beneficial renal outcomes regardless of the presence of diabetes. And the number needed to treat was 31 over a period of 26 months. A word of caution, the universal definition and classification of heart failure has changed after the initiation of this study. The Emperor Preserved trial defined preserved ejection fraction as an EF more than 40%. The current classification of EF, heart failure with preserved ejection fraction, is an EF more than 50%, so there was a discrepancy there, with 40 to 49 being retermed as mildly reduced heart failure. Therefore, with these results, it is safer to state that empagliflozin is beneficial in heart failure with both reduced and preserved ejection fractions ranging from less than 40 and going up to 60. Are SGLT2 inhibitors safe and effective in heart failure and diabetes? Sotagliflozin is a dual SGLT1 and SGLT2 inhibitor. The SGLT1 receptor is responsible for glucose absorption from the intestine. Up to this point, most cardiovascular trials enrolled community-based patients with stable heart failure. The Soloist worsening heart failure trial explored if sotagliflozin was effective and safe in patients with worsening heart failure. The primary endpoint was cardiovascular death, hospitalization from heart failure, and need for urgent heart failure visits. The trial did have some limitations as the trial funding was withdrawn, and it published its data in January 2021. This trial included diabetic patients who were admitted with a clinical syndrome of acute heart failure, who needed an IV diuretic and had a high BNP level. Some patients were left out of the trial, like the more advanced heart failure patients in end-stage heart failure, as well as those who have had an acute coronary syndrome during the preceding days. The sotagliflozin was restarted during the hospital stay or within 2 days of discharge from the hospital. It showed that sotagliflozin reduced cardiovascular death, heart failure hospitalization, and the need for urgent visits for heart failure. It was safe in acute heart failure, but however, severe hypoglycemia was slightly commoner, probably because of the SGLT1 inhibition. Another interesting study, a small-scale study using empagliflozin, tried to find out if the trial drug improved the visually assessed dyspnea score, whether it reduced the BNP levels, increased diuresis, and reduced the length of hospital stay in patients with acute heart failure. It found that it did not have an effect on the above, but however reduced the heart failure hospitalizations. So we presume that there should be some effect on any of these, but still the exact mechanism whereby it works is elusive. do SGLT1 or 2 inhibitors confer symptomatic improvement in patients with heart failure? Results from the DAPA-HF, Emperor reduced, Imperial reduced, and preserved, so many trials there, have given us varying results on the KCCQ assessment tool. However, there's another trial, a very small one, using canagliflozin, reported recently, which say that there is a significant improvement in the KCCQ occurring as early as 2 weeks into the study. But these need to be confirmed later on. Ertugliflozin is another SGLT2 inhibitor, and it is structurally and selectivity of the receptor is very similar to empagliflozin. And this underwent a CVOT, results being published about a year back, included about 8,000 patients, and they concluded that ertugliflozin was non-inferior to placebo, and superiority, like in the other drugs, was not demonstrated. Why this happened, they were not able to really explain, but they thought that maybe due to between class or between interclass difference in the chemical component might be the reason. Let us remind ourselves that diabetic kidney disease is estimated to affect about 50% of patients with diabetes. And again, presence of albuminuria and DKD increases the incidence of cardiovascular disease, with most ultimately dying of cardiovascular cause. Over the past 2 decades, ACE inhibitors and ARBs remain the only class of medication approved for slowing the progression of CKD. Several strategies have since been explored in patients with DKD with limited or no success. I'm not going to list the trials, you can have a look at them. The renal outcomes of SGLT2 inhibitors in their cardiovascular outcome trials offered robust evidence for improvement in renal outcomes. The renal outcomes were, however, not uniform across all trials. They used different renal outcomes like doubling of the serum creatinine, decrease in the EGFR, and so on. So therefore, there was the Credence trial was undertaken, and it was the first completed trial with dedicated kidney outcomes. And this trial used canagliflozin, and canagliflozin significantly reduced the risk of primary composite kidney outcomes in patients with type 2 diabetes with albuminuria and CKD. Since then, several studies are ongoing, several have already reported, trying to assess the place of SGLT2 inhibitors in patients with and without diabetes mellitus. DAPA-CKD has already reported its results and included patients with diabetes and without diabetes. The Fidelio DKD and the Figaro studies have also reported their results. I will come to them a little later. The DAPA-CKD found that in patients with CKD and albuminuria, dapagliflozin, regardless of the presence of diabetes mellitus, lowered the risk of end-stage kidney disease, decline in EGFR, or death from renal and cardiovascular causes compared to placebo. So again, we are getting very positive results in the dedicated renal trials. A newer drug, which I will just touch upon, finerenone is a non-steroidal MRA with a potent anti-inflammatory and anti-fibrotic properties. And 2 trials were performed, the Fidelio and the Figaro, which have reported their results very recently. And if you look at the study population of both trials, they are very similar. They included patients with diabetes, with CKD, with a fairly low EGFR, and moderate albuminuria. Their diabetes was well controlled, 7 to 7.5, and had very well controlled blood pressures, and subjects were already on guideline-directed therapies, including RASI, statin, and diuretic. The Fidelio trial, reported about a year back, found that the finerenone group had a lower risk of the primary outcome of renal failure, 40% reduction on EGFR, or death from renal cause. So it was beneficial. And it also showed a lower risk of the secondary outcome of cardiovascular death, MI, or stroke. As expected, hyperkalemia was slightly commoner in the trial group. Figaro was reported very recently, is more of a cardiovascular outcome trial and it showed among patients with type 2 diabetes and stage 2 to 4 CKD with albuminuria, finerenone reduced the composite of death from cardiovascular causes, MI, stroke, or heart failure. And this drug seems to confer additional benefit in addition to the current guideline-directed therapy. Another late-breaking trial, the Amplitude-O, studied the cardiovascular and renal outcomes of fp-glenatide in type 2 diabetes, which is a GLP-1 receptor agonist. It is an exendin-based GLP receptor agonist, and as you remember, exendin type of GLP-1 receptor agonist did not show very good cardiovascular outcome benefits in the initial trials. And this trial included about 4,000 patients with diabetes, with CVD or kidney disease, and one more cardiovascular risk factor. And they were on optimal cardioprotective medications, and the unique thing was, since it's a fairly new trial, it included patients who were on SGLT2 inhibitors as well. 15% of the patients were already on SGLT2 inhibitor. And they found that major adverse cardiovascular events was reduced by about 27%, and this was irrespective of the presence of an SGLT2 inhibitor. So the addition, this is the first trial that had an SGLT2 inhibitor and a GLP-1 receptor agonist being given concurrently. So if I just summarize the cardiovascular, heart failure, and the kidney outcomes with drugs used for the management of patients with type 2 diabetes, major adverse cardiovascular events seem to be reduced with both SGLT2 and GLP-1 receptor agonist. However, there are selective agents. Cardiovascular death has only been demonstrated with empagliflozin and liraglutide only 2%. Heart failure hospitalization is demonstrated with almost all the SGLT inhibitors and not a property of GLP-1 receptor agonist. Similarly, renal outcomes are solely the territory of SGLT2 inhibitors and not part of GLP-1 receptor agonist inhibition. Where do these medications now fit in treating a patient with diabetes? Is it time to switch from metformin as first-line therapy? What is the independence of HbA1c concept? If you just see the timeline of these medications being introduced, back in 2015, both GLP-1 receptor agonists and SGLT2s were recommended only for blood sugar control. But however, as the evidence accumulated over the years, cardiovascular benefits, renal benefits, heart failure benefits, now they are included in guidelines more commonly for their claimed benefits of cardiovascular events. 2021 ADA guidelines still recommends first-line therapy of metformin. And it is very specific and says that if you have ASVD, atherosclerotic cardiovascular disease, use a GLP-1 receptor agonist or SGLT2 inhibitor with proven CV benefit. Heart failure, very clear, it has to be an SGLT2 inhibitor. Diabetic kidney disease, it is again fairly clear that SGLT inhibitors take the edge here in retarding the progression of disease. The kidney guidelines societies also take the same stance, saying that with the general recommendations for starting or continuing metformin, if they are within that framework, metformin may be continued, but very strongly advocate the initiation of an SGLT2 inhibitor. So to summarize, newer agents of GLP-1 receptor agonist and SGLT2 inhibitors have a safe and favorable cardiovascular profile. However, not only in Sri Lanka, they remain globally underutilized, heavily underutilized. Cardiovascular mortality benefits remain inconclusive between agents and due to heterogeneity in primary outcomes. Intensified multi-target approach to reduce cardiovascular risk remains the best option for most patients. Not an individual drug, but your holistic approach. In keeping alongside all these clinical trials, quality of life assessment needs to proceed of hard cardiovascular and renal outcomes. Are we really making them any better or making them feel any better? And if you go through the current guidelines, they are very, very complex. We need to have simplified treatment protocols that are easy to follow at primary care levels across all countries. The take-home message I would like to give here is that adherence to established goals and treatment protocols should be maintained at all times. The evidence that is already there and what is there in guidelines. Metformin is a reasonable first-line medication in uncomplicated diabetes patients. In patients with ASVD, consider early initiation of a GLP-1 receptor agonist or an SGLT2 inhibitor with proven benefit. In patients with heart failure and or the presence of diabetic kidney disease, consider an SGLT2 inhibitor with proven benefit. Please remember that mostly cardiovascular benefits of SGLT2 inhibitors are a result in improvement of heart failure. Newer MRAs and the GLP-1 receptor agonists that I presented earlier needs further evaluation in further clinical trials before we recommend them. Thank you.
Thank you, Professor Madagama, for that interesting and up-to-date evidence lecture with up-to-date evidence. And as this is a plenary, we don't allow any questions. And I would, on behalf of the Sri Lanka College of Internal Medicine, I would invite my co-chair to present him a token of appreciation. Thank you. We'll move on to the next plenary. Thank you.